I don't think I've ever met anyone that has perfect symmetry or even close to perfect symmetry. Everyone has dominant side, non-dominant side. Everyone has a bit more strength, stability on one side versus the other. And even if it's just the perception of that, even if things are relatively similar from right to left, there's going to be a perception that differs in the way that they're moving one side to the other. And that's okay, and that's totally normal. But when that becomes not okay, is when there's issues or there's symptoms that are arising from that. So someone comes to you with, right shoulder pain, and you notice that they're having a really hard time creating scapular upward rotation. There's maybe a bias towards internal rotation, scapular elevation on that side. Then that's an issue because they're having symptoms because of that. So understanding that no one's going to come into you with perfect symmetry, but the better awareness you can create around these things, then that's going to increase their symmetry, which, especially if we're talking things like strength sports, like whether that's weightlifting, whether it's powerlifting, anything where they're on a barbell, symmetry is going to be the goal. In terms of athletic, field sports, it's going to be a little bit different, but the better awareness they have and ultimately the better symmetry they have, that's going to be something that protects them and makes them more resilient long term. But the better awareness they have of deviations from that, then that again gives them the autonomy to put themselves in positions that they're going to remain safe and they're going to be in stable, loadable positions over time. And if they're not, then they have, again, the awareness to deviate from that and change positions. So, of course, assessing sagittal plane front to back. A lot of times, the general deviation you're going to see is people biasing an anterior tilt. But we also want to look into their ability to laterally flex, right? If we have this crazy lateral flexion bias, we can have uneven shoulders due to purely scapular elevation on one side versus the other, or we can have uneven shoulders due to a lateral flexion bias, right? That could be a lateral flexion rotation of the spine, whether that's a structural or a functional scoliosis. In athletics, a lot of times you will see some degree of a functional scoliosis, especially anyone that's a thrower or has like a more unilateral biased position. Like talk to any baseball player, those motherfuckers got scoliosis. But as we assess these things, like, it's more common than not that it is a functional adaptation, right? It's not necessarily a thing that is just that is pre-existing, that they have this structural scoliosis that they're learning to cope with. No, the scoliosis is a result of the musculature that they're loading and the way that they're loading it. So looking into rotational capacity, looking into capacity to laterally flex, this is somewhere that either way, you can probably make a meaningful difference in someone's shoulder mechanics if you identify a discrepancy in the ability to rotate from right to left, on right to left, or laterally flex from one side to the other. So these are all considerations before we even get into shoulder mechanics. It gets a lot easier when we start talking shoulder mechanics, but these are things that we have to understand before we can even start talking scapula, before we can even start talking glenohumeral joint. Because if these things are underlying, it's still going to skew our data downstream. We're not going to get an accurate read on how someone's moving at the shoulder. We're not going to get an accurate read on their ability to stabilize the scapula. So this is priority number one, is that this is part of your assessment, but this is part of your assessment every single day. Is that I'm going to go through something when I walk in the gym with this person. Maybe we go through some soft tissue stuff, maybe lats, pecs are tight, whatever. Okay, cool. But now we're going to work through all three planes in the core. I'm going to get them to understand a posterior pelvic tilt. We're going to move through lateral flexion on both sides, and we're going to open up the distance in that rib cage in between ribs on both sides, so that we can create a better capacity now to push those ribs into the scapula to create stability. And same thing through rotation, as people will have rotational biases. So we want to be able to rotate the rib cage equally on both sides, or more symmetrically on both sides, because these are a lot of times the underlying issues to the things that are happening downstream. So once we understand that, once we get that, now we can start talking scapula. So as we start to look at the scapula, we're going to look at this kind of in I guess, two tiers. The first tier is going to be just kind of very two-dimensional, top to bottom, side to side. We can look at it. So that's going to be elevation, depression, protraction, retraction, right? And that's very generally just getting people to understand how to move the scapula around the rib cage, right? Creating better scapular stability. There's two movements that'll start people with, and this is like, the crazy thing is, like, people that don't understand how to do this, I've seen people that have gotten very far in strength sports, very far in athletics, even at the professional level, that don't really understand how to stabilize their scapula in isolation. And it's a crazy thing that this, like, it's so simple, it's so small, but it can create such a big difference in someone's trajectory in either athletics and performance, but also in just like health, in the reduction of the risk that they're going to have an injury at the shoulder. So that's literally the two movements I'll use is a scapula push-up. Put someone like on their forearms or on their hands, put them in a plank position, because you've already taught them how to create a posterior pelvic tilt and push that rib cage back into the scapula. But from here, you're just cueing with gravity. You're letting gravity pull their torso down, maintaining lumbar stability, and squeezing those shoulder blades together. Retraction. And then from there, it's active protraction, is that you're pushing that rib cage into the scapula. So this is exactly what I was talking about, I don't know, 20 minutes ago when I said scapular stability, which is rib cage against scapula, those two dinner plates stacked together. That's what this is that if you do this, if you have your clients do this, just fucking look at their scapula. As they go into retraction, the scapula's not even touching the rib cage. You can put your hand under there and you can feel the underside of their scapula. Retraction is not stability. And that's like, this is a side note, but that's like the big thing in rehab. Like, I don't know, even when I was in school, it was like, oh, someone has internally rotated shoulders, they need to get better at scapular retraction. And that's like, type in ChatGPT, like shoulder rehab, it'll say scapular retractions and external rotations. That's not the issue. You don't need to get better at retracting your scapula, because as you retract your scapula, you have less contact between the scapula and the rib cage. That's not what we're going for. That's the exact opposite of what we're going for. So as they go through scapular push-ups, you're not cueing retraction to get better at retraction. You're cueing active protraction to push that rib cage into the scapula. You're creating as much surface area contact between those two things as we can get, because that's going to be scapular stability. That's active scapular stability. So that's A1 every day. Every person that doesn't know how to use a shoulder, do that until you understand and you can feel that, what that's like to create that stability but between the scapula and the rib cage by actively pushing that rib cage into the scapula and pulling that scapula into the rib cage. That paired with a scapula dip, which is exactly what it sounds like. This is even, I guess, a lower tier than the scapula push-up, because in a scapula push-up, you need to be able to stabilize your pelvis. You need to be able to actively create that rib cage to pelvis orientation to be able to do this correctly. Scapula dip, so what I'm talking about is if you get a bench, you put someone's hands on a bench, you have their hips and knees bent to 90 degrees out in front of them, and you have them pull their hips off the bench, like walk their hips forward off the bench so they're in the top of a bench dip position. That's it. That's the starting position there. And the thing I really like about this specifically is that hips and knees are out in front of them, bent to 90 degrees. This is going to force them into a posterior pelvic tilt, right? It's going to take care of the rib cage to pelvis orientation for them so that they don't have to actively think of it. They're in the position they need to be in, so they can now focus on scapular movement. They can focus on scapular elevation and depression as they go through this. And then same exact thing, just fucking watch their shoulders as they go through it. As you get into scapular elevation, you're going to see like their shoulders come up. There's visibly less contact between the scapula and the rib cage. That's the passive part of this. Now I want you to actively create scapular stability by driving your hands down into that bench, and then you're going to pull your rib cage up into that scapula. And that's a scapula dip. And both of these things, you can go like this is why a plank is great. Like a protraction plank is great, because you can do these isometric and you can also do these for reps dynamically, they're both really good learning tools in different capacity. So for this sort of stuff, I'll typically start in more of an isometric, just because it makes it really evident as this is fatiguing when they're losing position. So you're building the capacity to hold this position, and you're also building the awareness of when you're losing the position. So you can go static to dynamic with these two movements, and the benefit of the dynamic is now they're creating an understanding of when they're voluntarily not in this position, when they're in shoulder elevation, when they're in scapular retraction, and then they're actively putting themselves back into a stable scapular position. So that's tier one. It's just understanding top to bottom, front to back scapula. Tier two is going to be scapular rotation. So I hinted towards this earlier. As we're watching someone's strategy to get their arms overhead, we're watching them. We're starting to build an understanding of their strategy to rotate or not, or avoid rotating the scapula. So as we get to this kind of link in the chain, is that the other things have to be going right. We have to have an understanding of pelvis to ribcage orientation, core bracing, number one. We have to have an understanding of scapular elevation, depression, protraction, and retraction before we can start to teach scapular rotation.